All right. So, hello everyone. My name is Najjar. I am a MS3 at Zucker School of Medicine. I'm interested in neurosurgery, in particular spine. And I've done some research in neurosurgery, and I actually just finished a selective rotation in neurosurgery last week. Before we start, why don't you guys just tell me where you guys are from, just to see where everyone's tuning in from? Awesome. Wow. Egypt, Mexico, Toronto, California. Wow. We have people all over. That's awesome. Somebody mentioned, can the slides be shared? The slides will be shared after the presentation. I'll reach out and make sure that those get posted. Okay, awesome. Great. What level of education are you guys at? Are you guys in college? Are you in high school? Are you guys med students? MS4s, college? Great. Undergrad. Nice. Awesome. That's amazing. Thank you guys for answering these questions in the chat. I'm going to try to keep this as interactive as possible. I'm going to ask you guys a lot of questions throughout. And if you guys have questions, feel free to ask. I'll try to get as many questions in as I can at the end, time permitting. And with that being said, we'll just go ahead and start. So let me just present. Great. Awesome. Okay. So just to start, does anybody want to talk really quickly in the chat what a general structure of the spine is, as well as a very important couple functions of the spine? Okay, yeah. So basically the whole idea here is the spine is really important, has a very protective role. And as you guys have seen in previous presentations, I know Brendan, who had the presentation last week on neuroanatomy for the brain, was talking a lot about structure and function. Structure and function is a very important theme in medicine. So the general structure of the spine, at least on the vertebral level, is it has 33 vertebrae. There are several sections of the spine that have different anatomy in each part, and we're going to go through that. So we have the cervical vertebrae, thoracic, lumbar, sacrum, and coccyx. Those are the different sections of the spine. There are 33 vertebrae, as I just mentioned. There's sort of this double S shape. I'm going to highlight. I don't know if you guys can see my mouse, but you can see here that there's this anterior convexity in the cervical spine as well as the lumbar spine, and this is referred to as lordosis. On the other hand, if you look at the thoracic vertebrae and the sacrum, the thoracic vertebrae and the sacrum, you can see there's a posterior convexity, and this is called kyphosis. So people I see in the chat have been mentioning things about protecting the spinal cord. That is exactly correct. The spinal cord will sit, and we're going to see this in further detail going forward. The spinal cord will sit in this part of the spine called the vertebral foramina, and that is really important for protecting the spine against lateral forces, axial forces, and any sort of injuries that can occur if there was a trauma wound, or and we're going to get into that in a little bit more detail. Other parts of the spine we should talk, or functions of the spine, is it helps with movement in all different directions, and there's cartilage that helps to ensure that this movement is as smooth as possible. There are several articulations of the spine. It articulates with the skull. It also articulates with the coccyx and the pelvis, and that helps to just keep one nice uniform structure. The spine also is a major site of hematopoiesis. Hematopoiesis is where you make cells in your blood. It could be red blood cells, white blood cells, just because of the bony structure of the spine that also helps contribute to creating cells. So then we talked about the general structure of the vertebral portion of the spine. Let's talk about the spinal cord, right? So there's different, somebody was mentioning in the chat, I saw that there's a motor component to the spine. And that is 100% true. This is where you get a lot of your motor movement. It helps coordinate your movement specifically. So you can see here that there's these different levels of the spinal cord themselves. There's a cervical, and there's also a cervical enlargement of the spinal cord. And we're going to see how that is going to be manifested within the vertebral structure of the cervical spine on the next slide, or the slide after actually. But there's that. You can also see that there's different sections of this spinal cord. There's this part down here at the L1 level called the conus medullaris. That's like the very bottom portion of the spinal cord itself. And then it becomes the cauda equina, and you can see that here. Does anybody know what cauda equina translates to? I believe it's Latin. Horse's tail, exactly. And you can kind of see that has this sort of frayed appearance down here on the bottom. And we're going to talk about the significance of the conus medullaris and the cauda equina in further detail in the next slides. So another important thing I'd like to talk about is the way the nerve roots exit the spine. You can see, you can't really see here, but I'm going to get into it. There's a little bit you can see here, but for the C1 to C7 levels, the nerve roots exit above their corresponding pedicles, whereas from the C8 spinal cord level and down, the nerve roots exit below the pedicle. And that's a really important point because the C8 spinal cord level does not have an associated vertebrae. So that's a really important point that often gets overlooked. And with that, we're going to keep moving. So further talking about the vertebral structure, you can sort of subdivide the structure of each vertebrae as the vertebral body, and that's on the anterior portion, and the vertebral arc, and that's more towards the posterior. You can see this spinous process here. When you're looking at imaging, or if you're just looking at gross anatomy, if you see the spinous process, you know you're looking at the posterior portion. Does anybody have an idea what the significance of the vertebral body is, especially when it comes to force and maintaining like an axial load? Weight bearing, exactly, perfect. Somebody put it right in there, exactly. So basically you'll see that most of the axial force and stressors that occur going from like top to bottom are really dependent on this vertebral body. So it's really important that the vertebral body remains structurally sound. The vertebral arc has this posterior portion, it also has these lateral portions. These lateral portions are called the pedicles. We were just talking about how the nerve roots can exit above or below them depending on what level you're at. And this sort of houses the spinal cord in this vertebral foramen. This is where the spinal cord will sit. Yeah, so another thing I'd like to talk about, and these are really important anatomical landmarks, especially when you're doing spine surgery, which I've been privileged enough to be able to see firsthand. This is a representative section of the lumbar spine. You can see the vertebral body here. These are the pedicles. This is the lamina right here. Laminas are really important if you were to do a laminectomy for various things, including for disc repairs if there was a herniated disc. Another really important point is the superior articular process and the inferior articular process. You can see on the lateral view on the side here, if you just connect the colors, this is the SAP and this is the IAP, and you can see that the SAP of one level connects with the IAP of the level superior to it. So for example, the IAP of T8 will connect with the SAP of T9, as you can see here, if you were to compare that. And this is how the vertebrae are connected. And this is very important because if you have issues with this, you can have all sorts of issues with stability and balance issues. And most of the time, this will need some sort of intervention, whether it's surgical or medical. There's going to need to be some level of intervention to manage the issues that are associated with this. So now if we look at the vertebral anatomy by each level, we were just talking a little bit about how there was a cervical enlargement. And you can see here, so this is the cervical vertebrae, this is thoracic, this is lumbar, this is sacral, and this is coccyx. So the coccyx is actually down here. So you can see as you go from the cervical spine to the lumbar spine, the vertebral body gets larger and the vertebral foramen gets smaller. That's really important because the vertebral foramen is going to be larger in the cervical spine to handle or to accommodate the cervical enlargement of the spinal cord that exists as the nerves exit the skull. And this is going to be closest to the foramen magnum at the skull base, right? Another important part of this is the transverse foramen. You can see here, number 3 here. The transverse foramen is really important because this is where the vertebral arteries, veins, and sympathetic fibers pass through before entering the foramen magnum. And so we talked a little bit about the thoracic spine. We're going to talk a little bit more about it here. Basically, it has the smallest vertebral foramina, and it has like an intermediate size vertebral body. And yeah, so that's basically the thoracic. Here's a lumbar. We talked about on the last slide how it has the largest vertebral body and a very small vertebral foramina. And here is multiple views of the sacrum. You can see that there's anterior sacral foramina as well as posterior sacral foramina. This is really important because this is where nerve roots at that the S level, like S1 to S4, this is where those nerves will leave, and that helps to innervate a lot of abdominal pelvic viscera, visceral structures. Looking a little bit more at the spinal cord itself, you can see that this is a nice posterior lateral view of the spinal cord. You can see the spinal cord sitting nicely in this vertebral foramina or foramen, and you can see the spinous processes back here. You can also see the discs. The discs are in between each vertebrae, right? And the disc has like an annulus and the nucleus pulposus in the middle. You can see the nerve roots exiting above the pedicles in this situation. And another thing that we can talk about is anesthesia and lumbar punctures. Does anybody know what the utility of lumbar punctures are? CSF, great. And what would you be? Oh, exactly. Somebody just mentioned diagnosed meningitis. Yes, a lot of times you can do lumbar punctures to see if there's some sort of CNS involvement in an infectious process. And this person just mentioned meningitis, which is exactly on point. So let's talk about how that would happen. Let's talk about, before we get into the actual procedure, let's talk about something that's very important, which is the positioning of the patient. Something that's very important in neurosurgery that I've noticed is the positioning of the patient, whether it's cranial surgery or spine surgery. No matter what, the patient has to be situated appropriately in order to have the most correct access to the structures that you're trying to operate on. So what you can see in the bottom right corner here is a position for a lumbar puncture, which is also going to be similar to the position for an epidural during labor and delivery when someone is pregnant. So you can see you would have the patient lay on their side, curl their knees towards their chest, and have them curl their head down towards their knees, sort of like in a fetal position. This allows for extra space in these spinous processes that you can see here to allow the needle to insert into the right location. Now, there's going to be a difference in this location that the needle is going to penetrate based on what you're trying to do. So if we were to start with an epidural that people use during delivery to ease the pain that is associated with delivering a child, first you're going to start with the skin, then you're going to get into the supraspinal ligament, then you're going to get into the intraspinal ligament, which you can see is around these spinous processes. Then you'll get into the ligamentum flavum. At the ligamentum flavum, you'll hear an audible pop when the needle penetrates that. And then from that point, you will reach the epidural space. Now, people always talk about, this is the epidural, I want an epidural. This is exactly what they're talking about. There's anesthetics that could be administered into this epidural space that helps to reduce pain, especially during pregnancy. So if we were going to continue, and this was a lumbar puncture, now we're in the epidural space, you're going to reach the dura mater, and then you're going to reach the arachnoid mater, and then the subarachnoid space. CSF is in the subarachnoid space. So if you were suspecting that someone potentially has meningitis, they have fevers, they're not feeling well, they look, out of, like disheveled, and they have like that sort of nuchal neck rigidity that's very characteristic of meningitis, you would place a lumbar puncture into the subarachnoid space to see the CSF, and then you can test that CSF to see if there's any presence of bacteria, and they look at proteins and lymphocytes and neutrophils and all sorts of things that you can look at in this lumbar puncture. to make a firm diagnosis. So that's basically the spinal cord on a clinical level. Continuing on, let's look at different cross sections of the spinal cord. The spinal cord is different in the sections of the spinal cord are different at each level. And there's a reason for that, and we're going to get into that. So you can see that the cervical, thoracic, lumbar, and sacral all look different, but they all have a dorsal horn and a ventral horn. I don't expect anybody to know this, but just for fun, does anybody know what the function of the dorsal horn is in the spinal cord? People are saying motor. Somebody said sensory. Exactly, sensory. This is where sensory information is connected into the spinal cord. People were mentioning motor. Motor is handled by the ventral horn. Now, you can also see that the lateral horn exists at the level of the thoracic spinal column. The lateral horn is involved with autonomic functions, functions that you don't have voluntary control over, functions, to innervate visceral organs. So let's look a little bit more about this, right? These are just the representative sections. You can see that there's a large dorsal horn in the cervical and the lumbar cord, and that's really important because those sort of parts of the spinal cord are really involved with innervating sensory functions such as like the skin. And so if we're going to look at this a little bit further, does anybody have an idea what level of the spinal cord we're at in this representative section here on the right? If you were to compare to the images on the left. See lumbar, see cervical, thoracic. Exactly. This is the thoracic. Why do we know that this is the thoracic spinal cord? Because you can see the lateral horn. That's very unique to this region, right? So let's just sort of get into this. I'm not going to go all the way into this topic. There's whole weeks of med school that you'll have to learn about this innervation, but I'll give you a sneak little preview, especially for those who are interested in going to medical school or just, interested in this topic in general. It's very interesting. So getting into this a little bit more, we're going to start the lateral horn, right? You're going to have a cell body. These circles are cell bodies. These arrows are synapses. So if we start at the cell body here in the lateral spinal cord, in the lateral horn of the thoracic spinal cord, you're going to see that you have a visceral efferent coming out, exits, goes through the anterior horn, enters the anterior root, hits the spinal nerve, goes through the white ramus, synapses in the paravertebral ganglion, exits through the gray ramus, and then goes on to innervate a lot of different autonomic functions. So for example, in your skin, you can see that this is like how sweat would be generated. This is how your adrenal glands would work. This innervates smooth muscle, things that you don't have control over that are functioning all the time that you would never even realize. On the other hand, let's look at some voluntary motor control. And these are called somatic efferents. You can see that the cell body starts in the ventral horn or the anterior horn, whatever you prefer, starts in the anterior horn, goes through the anterior root, hits the spinal nerve, and then it can go on and innervate all sorts of different things. For example, in this situation, skeletal muscles. So if you were to flex your hip or anything or raise your toes, this is how that would work. Now, going the other direction, we're going to have information. You can have information going from the spinal cord, from your brain to the spinal cord, and then to an organ or a muscle. On the other hand, you can have organs and muscles send information back to the spinal cord and then eventually back to the brain through a bunch of different pathways we're not going to get into today. I wish I could, but we'd be here till next week. Something that we can talk about is, say, you're feeling pain in one of your muscles, right? So here's a skeletal muscle. You can also have this in joints or skin, but for the purposes of today, this is what we're going to talk about. We're going to talk about the skeletal muscles. So this is called a somatic afferent fiber. So you can have a fiber coming from the skeletal muscle, enters the same way that, the other ones left, ends up going into the spinal nerve. It has a cell body in the dorsal root ganglion, and then it travels through the posterior root and synapses in the dorsal horn. Similarly, visceral afferent, so some sort of sensory information from different organs can come through, do the same thing, cell body in the dorsal root ganglion, and then eventually synapse into the dorsal horn. I know that was a lot. It takes, time and practice of going through these different pathways and sort of just picking a muscle or an organ and tracing the pathway back through the different levels. And it's very rewarding once you figure it out. I'll tell you that. So the next thing we're going to talk about is the spinal tracts, right? Spinal tracts, we were just looking at that representative section of the spinal cord. This is very important. So there's different tracts that can occur here. They all have different functions. They synapse at these different areas, and they provide all sorts of different innervations. So for example, you can have the lateral cortical spinal tract that's involved with motor functions, the dorsal columns. This is really important for fine touch and proprioception and vibration. So in other words, if you were to see someone do a neurological exam, you can see them place a tuning fork that's vibrating on their top of their foot and see if they can notice that feeling. If that feeling is not there, you can have a suspicion that the dorsal columns could be involved in some sort of pathology. That's definitely something of importance. You also have the spinal thalamic tract. This is involved with pain and temperature sensation. And so you can see that there's sort of a difference here between your ascending tracts and your descending tracts. You know, your motor tracts are generally descending, your sensory tracts are generally ascending. And sort of just that is the lay of the land with the cross section of the spinal cord. Pushing along a little bit more, we can talk about the blood supply of the spinal cord, which is very integral to maintaining the hemostasis and physiological hemostasis in the spinal cord. So we can see here that you have there are three origins of spinal vasculature, right? Two vertebral arteries can come off and they converge into one and become the anterior spinal artery, right? That anterior spinal artery is shown here, right? On the other hand, there are posterior inferior cerebellar arteries. So in the cerebellum, closer to your brain, those each can converge down and become a posterior spinal artery, as shown here. This is really important because you can see there's only one anterior spinal artery, or ASA, and there are pairs of PSAs. Does anybody have an idea how this can become of clinical significance? I like how one of you guys mentioned it. If ASA is obstructed, we are in big trouble. That is exactly true. I couldn't have said it better myself. And that's because you don't have as much collateral or anesthetic blood supply. One thing that can help, somebody mentioned collateral bunches. One thing that can help is this watershed region called the artery of Adamkiewicz. It provides like a collateral blood supply by anesmosing or connecting with the ASA. So this helps to maintain adequate perfusion so that there's no hyperperfusion events, or if there was, unfortunately, some thrombotic or occlusive or stenotic event, that there's a way that this can still get, the anterior part of the spinal cord can still get blood supply. Now, this is just for fun. What would happen? What tracts would be affected if I were to have an issue with the blood supply through the ASA? Any idea of like what sort of dysfunction, just generally, what you'd see? Perfect. You guys are right on point. Motor, autonomic could also be affected. You know, you can sort of see here, this circle area here, this can definitely be affected. It really depends on what level of the spine you're at to have an autonomic issue, but for sure motor, the descending tracts would definitely be affected. You could also have some issue with the spinal thalamic tract, as you can see here. Spinal thalamic tract, as we mentioned, temperature and pain sensation is involved with the spinal thalamic tract. So yeah, you guys are right on point. That's great. Another thing we need to talk about, I mentioned there's three origins. We talked about the vertebral arteries converging to form the ASA. We talked about each posterior inferior cerebellar artery converging to form a posterior spinal artery. Now, the last one we're going to talk about is a segmental artery. Those come from the intercostal arteries. Does anybody know where the intercostal arteries are generally located? Ribs, exactly. And that's really makes a lot of sense, right? Because especially at this level, the thoracic vertebrae, they converge with the ribs. So it sort of follows that the intercostal arteries, which you'd see located around the ribs, also help to converge and form a segmental artery. So you can see that the segmental artery branches out into these anterior and posterior radicular arteries, and those end up contributing to the blood supply in the anterior and posterior axes of the spinal cord. So great, we're doing great right now. I might have to pick up the pace a little bit because we are a little behind, but just bear with me. I'll try to explain everything as quickly and efficiently as possible. Now, let's look at some imaging of the spine. Imaging of the spine is so important. That is one of the things that they will do if you have any sort of spinal issues. A lot of times they would want to see imaging to see what's going on. Now, on the left, you can see a sagittal T2 image of the spine, and you can see a sagittal T1 image on the spine on the right. Does anybody know the difference between T1 and T2 MRIs? Yes, great. Fluid glows in T2. Exactly. T2, you can see a lot more fluid. It is more indicative of fluid, and you can see where the fluid boundaries are. Another good way to remember it is T2O, like H2O. So that's a good way to remember the difference between T1 and T2. I use that to this day still. T1 highlights fat more than anything. So you can see differences in the lighting patterns on both sides. Now, you can see we have these nice vertebrae. This is a normal image of the spine, right? And you can see in between that there's these like little, bright areas. Those bright areas are the vertebral discs, right? And we talked a little bit about this on a previous slide. There's the nucleus pulposus and the annulus fibrosus that holds the disc in place, right? And you can see that there's the spinal cord sitting nice in the vertebral foramen. Here's the epidural space, the subarachnoid space. We have the spinal nerves exiting as roots, in this case, below the pedicles, which makes sense. So let's see what happens when things go wrong, right? Especially on imaging. What do we see here? This is what we see. We see an annulus that has an issue, the nucleus pulposus kind of leaking out a little bit, affecting the left side of, it's impinging onto the left nerve root, exiting around the region of the pedicle. This is a axial version of that. You can see the same thing happening here. And here's a sagittal version of that same sort of pathology we're talking about. In this case, the disc is bulging out and impeding on the spinal cord, as you can see here, at the level of L5S1. First of all, we talked a little bit about what orientation the nerve roots come out of. We said that there's a difference in the nerve roots, how they exit at the cervical level and below that cervical level. Does anybody remember what that was? How the nerve roots exit in relation to the pedicle? Great. So somebody mentioned, yeah, so it's below from C8 and down. So below C8 or C7, the nerve root will exit below its corresponding vertebrae. Above that C7, C8 level, the nerve root will exit above its corresponding vertebrae. And that makes sense because the C8, there's no C8 spine. There's a C8 spinal cord, there's no C8 vertebra, right? So right here, what nerve root would you say is being impinged? You have, this is the L5 vertebrae and the S1 vertebrae. So which nerve root here is being impinged? Somebody said L5. Exactly. So, and there's different types of herniation that occur. You can have a central disc, a disc sequestration, and all sorts of different ways that this nerve can be impinged by a disc protruding, right? What do you think the patient would present with if they had an L5 impingement, also known as an L5 radiculopathy? What do you guys think the patient would have difficulty with? Sciatic nerve pain is definitely part of it. Yes, definitely. So let's get into this a little bit more. If we look at this, right, the spine, the nerves that exit the spine have a dermatomal and a myotomal distribution. Dermatomes meaning sort of a skin sensory sort of innervation, and myotome meaning a muscular motor component to this innervation. So you can see they kind of are in the same regions, and they're going to have very specific functions that they do. Somebody mentioned, this is really important actually, are herniated discs fixable? Herniated discs are fixable. There are a lot of different things you can do. There's fusions, there's laminectomies, depending just on what's going on with the actual disc herniation, the level of its herniation, the shape, where it's herniating. There's a lot of different things that can be done, especially with all the new modern advancements in spinal surgery. A lot of these surgeries don't have to be as big a deal as they used to be in the past. You know, there's better technology, there's better instruments, there's better equipment, and the surgeries can have less complications, and they can be shorter in duration, and people can get back on their feet much faster than they used to be. And it's really a very promising field. So we were talking a little bit about dermatomes and myotomes, right? So we have a skin distribution and a muscle distribution, right? And they, you know, half the time, you know, they are, you know, in the same area. So you can see here that there's the L5 is right down here, going towards like the anterior tibialis muscle on the front side of the shin, and it goes towards the top of the foot. On the back side, you can see it has this area in the back, goes down on the lateral hip and goes down. So basically you can have an L5 distribution of numbness, and you can have an L5 distribution of motor dysfunction, right? So we see here that L5 is involved with dorsiflexion. So basically pointing your toes towards the ceiling. Someone who has an L5 issue will have a lot of difficulty walking on their heels. And they'll also have this pattern of numbness going down. There'll also just be pain. And, you know, sometimes you can see this in sort of like a sciatic nerve pain. So that's basically how that goes. Oh, somebody, I guess herniated disc became very interesting topic to a lot of people. I love it. So can herniated disc regress spontaneously? Over time with medical treatment, the disc can sort of realign itself. It's a very long, troublesome journey for a lot of people, but, you know, there's a lot of medications that you use to reduce inflammation, like steroids and NSAIDs. And, you know, a lot of people are able to also just have their herniated disc sort of realign itself. It may not be as good as it was, but you can have like a regression of some of these symptoms with just, you know, simple medical management, as well as a lot of physical therapy. So let's get into some cases, because we know you guys like cases, and it gets everybody thinking, especially towards the end. And thank you guys for bearing with me. I know I just threw a lot of information at you guys, but you guys have been great. So first case is a 16-year-old female is seen by her primary physician for a normal checkup. During a routine exam, he notices that her shoulders and waist appear uneven. The physician orders an X-ray, which is shown to the right, and I'm going to show that. What is causing the uneven shoulders and waist in this patient? Before I show the X-ray, let's just see just very quickly what you guys have on your working differential. Scoliosis. Wow, you guys are good. This is scoliosis. You can see that there's sort of this really bad shape of the spine. It's an S shape. There's an upper curve convex at the right, and the lower curve is on the left. And so that's basically what's going on here. So how do we go about treating this? That's a very important topic. There is a lot of different treatments you can have here. The right is post-op. This is pre-op that we just saw on the previous slide. You can do a spinal fusion, and that's sort of what's being shown here. There's a lot of rods, screws, and wires that can, you know, be used to realign the spine and provide more structural integrity. You know, the advantage is it's like definitive treatment, and you don't have to worry about having this uneven posture and a lot of the nerve issues and physical and balance issues that you can have with scoliosis, especially when it's really bad. Like in this case, like imagine, you know, we talked about how the spinal cord sits in the vertebral foramen. Imagine what the spinal cord looks like in this situation. And sure, it's very bent and not in its correct location. So yeah, so we can basically, you know, fuse adjacent vertebrae together and make them like one whole, like uniform body, or like almost like one whole bone. So, you know, obviously there's going to be advantages and disadvantages to every surgery. Sometimes with these surgeries, depending on how the what the deformity looked like and what could be done given the situation, sometimes you can have some issues with flexibility and mobility at the regions that were fused. But, you know, with modern advancements in this type of surgery, less segments of the spine need to be fused, less levels need to be fused. And, it can just be done at a higher level now. And so people have less long-term consequences and sequelae following these surgeries. So they don't have to necessarily have less mobility and flexibility at these levels. So that's a really important case. We're going to move on to the next case. Somebody says her spine done growing at this point. To be honest, I'm not exactly sure, but yeah, I'm honestly not entirely sure. It's a very good question. So going on to the next question, the next case. This is a 50-year-old male. He's referred by to a neurologist by his primary care doctor because he had concerns about pain in his neck, upper chest, and upper back. The patient also mentions that his forearms have become increasingly numb and weak. So just from this, without even looking at the image, what sort of things are you concerned about? Number one. Number two, let's talk about this distribution of pain and numbness and weakness. We talked a little bit about dermatomes and myotomes. Okay, so you guys are in the right level, or close to the right level. Somebody said C-level spinal cord damage. This is a type of damage where just below the level of the cervical spine. Spinal stenosis is definitely something that can cause a presentation like this. So we're in the thoracic spine, exactly. Do you guys think that there's a rhyme or reason to this pattern of numbness and weakness and pain? And somebody's asking, is this a tumor? This is a tumor. We're going to get into that. Okay, so let's just get into this a little bit more. So you can see on the right here, this is a sagittal T2 MRI. You can see that the fluid is being as intense here. And so this is a homogeneous enhancing intradural extramedullary mass with a broad dural base, right? There's dural tails. We're going to see that in more detail. And it's in the vertebral canal, and it's pushing anteriorly, right? So and this is at the level of T1, and it's causing significant cord compression and flattening of this cord. You can see that the CSF space that would be right around here is almost completely obliterated. So that's basically what this is looking like. And so you can see here further that this is the tails, the dural base tails, and this tumor is called a meningioma. Meningiomas are very common. Most of the time, they're very benign. There's different level of WHO grade classification scales. There's grade 1, 2, and 3. And those grade 1 is benign. Most meningiomas are benign. They can be malignant, but they tend to be benign, and they can be removed. I actually have seen meningiomas in this level of the spine be removed, and they can have great outcomes and low levels of recurrence, which is what everybody always wants to see with these kind of procedures on tumors. So that brings us to our next case. So people are talking about, somebody was asking, are meninges slow or fast growing? Based on the WHO grade classification, they can be slow or fast growing. Generally benign meningiomas can grow pretty slow. Somebody also asked, is operating the area of the thoracic spine more risky than in other spinal areas? Difficult approach, important structures. Different spinal areas have different levels of complexity and their own complications that occur, right? Operating the cervical spine is incredibly dangerous because of all the different things that can happen below the cervical spine and everything that it serves to innervate. C4, 5, 6 are helpful in innervating the diaphragm. If you have issues with those levels of the spine, you can just have issues with respirating, and that can lead to death. And it's really unfortunate. There's also different levels of this, like every level of the spine has its own complex, unique issues. And so it's just, you have to have particular care and attention being paid. And there's a lot of preoperative planning and imaging and navigation. There's a lot of different technologies that are offered by a lot of different companies that can provide navigation, so you know exactly where you're going. And a lot of times to do intraoperative CTs and MRIs and X-rays to see where they are and, in relation to the issue that they're trying to rectify. Can meningiomas present differently depending on the location? Yeah, it's really depending on what's being compressed. If this meningioma was compressing a lumbar spinal cord level, you'd see, like, you could see things that look similar to like sciatica, right? It could compress like the L5 nerve root, and you can have a similar thing. In the brain, you can have a meningioma, and it can present with confusion or difficulty with speech, just really depending on where this meningioma is situated. So that's sort of something to always keep in mind. So case 3, this is a 36-year-old male presenting to the ED after a 3-story fall from a ladder while painting his house. This is a very common situation that you'll see in the emergency department. After coming to, he notices he can't move his limbs, his lower limbs, and he has perianal numbness as well as other sensory disturbances in his lower limbs. He also has lower back pain that he rates 10 out of 10 in severity. Neurosurgery is consulted, and physical exam shows hyperreflexia in his legs. Of note, the patient appears to have lost control of his bowels. So what do you guys think is going on here? Somebody tell me what you guys see in this CT on the right. Yeah, so there's a fracture. Somebody mentioned cauda equina. That's very close. You are incredibly close. This is at the level of L1. Now, we talked a little bit earlier about there's a difference between the cauda equina and the conus medullaris. At the level of L1, we are seeing here that this is called a burst fracture, and it's impinging on the conus medullaris at the level of L1. This is referred to as conus medullaris syndrome. Now, this can be contrasted with something called cauda equina syndrome, where the cauda equina is being compressed. And you can see in this chart on the left that there's a difference in the presentation. Both are very serious, but one of them is more acute than the other. The more acute issue is the conus medullaris syndrome versus cauda equina. Cauda equina can be gradual, and it can only be one-sided, and it can be slow in terms of progression. Whereas conus medullaris is immediate, it's acute, what happened, you have to go to the hospital, it's bad. And not that the cauda equina syndrome is not bad, but I'm saying in terms of acuity, conus medullaris is much more acute. And you can see there's also some, characteristic findings that are different between each, right? Bilateral versus unilateral. You can have perianal numbness versus saddle area numbness. And one thing, they both have urinary retention issues because the innervation to the bladder is being affected. But in conus medullaris syndrome, you also have fecal incontinence, which we saw in the patient presentation on the previous slide. The patient had lost control of his bowels, and so things like checking anal sphincter tone, as well as seeing for incontinence or urinary retention, these are characteristic signs of these disorders or issues, and it's part of the clinical diagnosis. So just reviewing really quickly, you can see the conus medullaris, which is the termination of the spinal cord. This happens at like the level of L1. You see the cauda equina comes in below it and is like this frayed nerve root looking structure. So that is the difference between those two. Another thing that we could talk about is how cauda equina typically manifests with lower motor neuron signs, whereas conus medullaris presents with upper motor neuron signs as well as lower motor neuron signs. So the upper motor neuron signs are going to be at or below the level of compression, while the lower motor neuron signs are at the level of the compression. Now, I'm saying upper motor neuron and lower motor neuron. Upper motor neurons come from the brain, synapse in the spinal cord, and then lower motor neurons go from that spinal cord down to the muscle of choice, right? So upper motor neuron issues have this hyperreflexia that can occur, whereas lower motor neurons do not have this hyperreflexia that can occur when you see it as an injury itself. And so we talked about on the previous slide that this patient had hyperreflexia. That should already mean automatically that this is an upper motor neuron injury to an extent. And this is because, upper motor neurons are more involved with the inhibition of motor function. So if you lose the inhibition, you're going to get this hyperreflexia. If you take a reflex hammer and you hit someone's knee in that area, you'll see their leg kick up way higher than it should. And you'll also see like a spasticity. And, this is because you lost the inhibition that upper motor neurons provide. What do I mean by hyperreflexia? Hyperreflexia meaning, when you go to the doctor and they take the reflex hammer and they hit you on the knee and your knee kind of jerks a little bit, has like a little bit of a kick to it. Hyperreflexia, if you do that, your foot will kick so much higher. It's like disinhibited level of reflex. It's hyper reflex. So yeah, of course, no problem at all. Happy to answer questions. So next case, and we're doing actually good on time. We got just a little bit of time left for these last two cases. So this one is really complicated, but I feel like we have the tools in order to solve this problem. And I think we're going to get into this and we're going to spend a good amount of time talking about it. So 22-year-old male presents to the ED after a bar fight. He's brought into the ED in the prone position on a stretcher. A knife is sticking out of the right side of his middle back, and a neurological exam is performed, and the findings are below. So on the left side, there's loss of pain, temperature, and non-descriptive touch sensation in the lower abdomen. On the right side, there's loss of proprioception, vibration, and tactile discrimination from his lower abdomen down. Additionally, there's segmental flaccid paralysis in his lower trunk, and there's spastic paralysis below his lower abdomen. There's also a Babinski sign. Babinski sign is something you'll see in an upper motor neuron injury. And it's basically you rub like a sharp surface on the sole of someone's feet, and you can see that their foot will react to that, and that is the Babinski sign. Yeah, somebody just mentioned upper motor neuron damage due to Babinski. And somebody also just answered this question. That's amazing. This is Brown-Séquard syndrome. That is incredible. I love it. So let's talk about Brown-Séquard syndrome. This is an issue that happens when there's a hemisection of the spinal cord, right? You can see here in yellow, this is the issue with the hemisection, right? There are ipsilateral and contralateral features to this that we saw in the clinical presentation in the neurological exam on the previous slide, right? You can see on the same side of the lesion, so ipsilateral, there's upper motor neuron weakness, right? So you're going to see this hyperreflexia, you're going to see this spasticity, right? And you're going to see this just weakness in general. You're going to also lose your position and vibrational sense, right? Now, we talked about on the other side, you're going to have opposite the lesion, there's a loss of pain and temperature, right? Over here, we have the spinal thalamic tract. Now you're thinking, why are we having contralateral loss of pain and temperature sensation when it's on this side? Why is it going to the other side? At the level of the spine, the spinal thalamic pathway crosses over the spine at that level, and synapses on that side. So for example, your right leg goes to your left spinal thalamic tract. So if you rubbed a pin on your leg, you'd feel it on your right leg, that sensation would be transmitted to the left spinal thalamic tract of the spine. Whereas for other innervations like motor, they decussate or cross over much higher at the level of like the brainstem and the medulla, right? So going through this a little bit more, this is the exact physical exam that we saw on the other side. You can see the damage region here, right? There is dissociated sensory loss of temperature and pain contralaterally, as we said, because the injury is on this side, on the patient's right side. You can see that this is the patient's right side of the spinal cord, right? You can see there's flaccid paralysis at that level. There's complete loss of sensation at this level here. Down here, there's loss of proprioception, and and there's spastic paresis on this side as well. So it's exactly the presentation that we had just saw. So this is very confusing. I encourage you guys to just spend a little bit of time and look at it and just play with it as much as you can, and eventually it will come to you. I know it takes some time. So that is case 4. That was definitely a tough one, and this is the last case we have, and then I'll take 5 minutes to answer questions. So this is a 62-year-old female with diabetes, hyperlipidemia, hypertension, and coronary artery disease with a recently discovered abdominal aortic aneurysm. So right away, you already know this is much different from the case we saw before. There's less of a structural component to this, right? So open surgery was performed to repair the aneurysm. Post-operatively, she's unable to move her legs and has loss of pain and temperature sensation bilaterally from the mid-abdomen to the toes. But she does feel light touch and vibrations from the tuning fork in these areas. So based on what we talked about a little bit, I mentioned the tuning fork before. I talked about motor movement and pain and temperature sensation. Do you guys want to try to sort of pinpoint what parts of the spinal cord, in that cross section seem to be working and what doesn't work. Let's start with what's working. Let's start on the easier side. She feels light touch and vibrations from the tuning fork. What sort of part is working? Sensory, but specifically dorsal column. Exactly. The dorsal column is intact, because as we saw before, I'm going to just run back through these cases to give you guys the quick refresh. The dorsal columns for fine touch and proprioception and vibration, like the tuning fork, is intact, right? So we just looked at that. The next part, breaking this down further, she's unable to move her legs and has loss of pain and temperature sensation bilaterally. What is the pain and temperature sensation loss? Spinal thalamic and cortical spinal tract. Yes, so the cortical spinal tract for motor, that's why we don't have an issue, why we don't have motor function here. And the spinal thalamic tract is involved with pain and temperature sensation. So clearly the cortical spinal tract and the spinal thalamic tract are both being affected. The DCML is intact. So what do you guys think is going on here? Now that we've sort of broken down what the disturbances are. Something happened to the anterior spinal artery. Exactly. Somebody said ischemia. Okay, you guys are right in the right ballpark here. So further going through this, you know, we saw this image before, right? Here's your anterior spinal artery. Here is your posterior spinal artery, right? They're functioning down. We have the artery adempquis providing that watershed area with collateral and anastomotic blood supply. You can see in the cross section, we have the ASA here providing the anterior spinal cord, posterior providing the posterior spinal cord, right? And you can see here, this is another schematic of what's going on. So basically what the whole idea here is that aortic repairs can result in injury to the artery adempquis. And so therefore, you know, it can cause an issue with this watershed area. And it's the only major vessel that supplies the spinal cord below the level of T8T9 for this ASA anterior spinal cord distribution. Which one would you say is more rare to have? An issue with the PSA or an issue with the ASA? Would you say a posterior cord syndrome is more rare or an anterior cord syndrome is more rare? Exactly. Somebody had it right on point. Posterior cord syndrome is much more rare than anterior cord syndrome because, as we talked about before, there are paired branches of the PSA to supply this posterior region, whereas the ASA only has one branch. So, you know, you can have a little bit of collateral supply from the other PSA. You know, if you knock out one, you have the other one at least. You can still get some innervation or blood supply, right? If you knock out the ASA, that's it. You don't really have anything else that's really providing that much for you. So that's really important. Now we talked about what ASA spinal cord issue or ASA distribution of vasculature to the spinal cord. If there's an issue with that, what it would present with. Now let's talk about what, if you messed up the PSA, what that would look like. What sort of findings would you expect to see if you did a neurological exam? Loss of sensation. Okay, give me a little bit more, just a little bit more detail. Yeah, so you could have issues with proprioception, vibration sense. So if I put a tuning fork and I put it on your foot, you wouldn't really be able to notice it as much. And yeah, so you guys are right on point. This is affecting the DCML, the dorsal column of the spinal cord. So that is basically that. Looking a little bit more about the ASA syndrome, you can see down here, you have dysfunction of the bladder and the rectum because the lateral horns are affected. We talked about how the lateral horns are implicated in autonomic innervation. You can see the damage region here is in pink, which is, you know, right along this anterior portion of the spinal cord. There's also loss of temperature and pain, as we said, because we lost the spinal thalamic tract that's like right down here. Spastic paresis from the upper motor neuron injury, that would be right here, the cortical spinal tract, and the flaccid paralysis from bilateral damage to both anterior horns at the segment level. Exactly. It's exactly what we were talking about, the anterior horn. And so with that, I'm going to conclude my presentation. And this is my name, my contact info. Should you guys want to reach out about anything, like feel free. Happy to answer questions. And I have like, let's say let's like 2 to 3 minutes for questions. What questions do you guys have? Thank you guys. I appreciate it. And I'm glad you guys were able to learn so much from this presentation. I enjoyed making it, and I love talking about this stuff. This is like some of my favorite things to learn about. Glad you guys had fun. Awesome. Okay, so Quinn, I will turn it over to you. Thank you so much.